Our other moderator is Dr. Fozia Sirin Hakim. She passed MBBS and MS from Assam Medical College, Dibrugarh. She was the research fellow and also senior research officer at All India Institute of Medical Science, New Delhi. She completed certificate course on allergy and immunotherapy and did certified course for assessment and management of vestibular disorder. It is a NEA certified course. She is presently the director at Hakim's JK ENT Clinic and Research Center, also senior ENT consultant in NF Railway Dibrugarh. She is also associated as senior consultant of ENT at various hospitals of Dibrugarh. She has been invited as faculty at national and regional conference. Apart from members of various association of ENT, she is also a member of Rotary Club Dibrugarh. This is about their short biodata. Now I welcome Dr. Ruby Dole, the today's speaker, to the classroom. Over to Ruby Dole.
Thank you, ma'am, so much. Am I audible to everyone now?
Yes, you are audible.
Thank you to Niboy at the onset for giving me this platform today. And without wasting much time, let us now start with today's topic. So today I'll be speaking on the topic of Ramsay Hunt syndrome associated labyrinthitis. And we had a case study on 4 patients in our hospital, and I'll be discussing the observations which we further derived from this study. So in June 2022, the famous pop star Justin Bieber publicly announced that he had Ramsay Hunt syndrome. He revealed the diagnosis in a video on his Instagram profile showing the paralysis on one side of his face, and which led to cancellation of several tour dates and a huge hullabaloo at that time. So what is Ramsay Hunt syndrome? It was first described by Tride in 1872, but only in 1907, 60 cases were first time described by the American Army officer and neurologist named John Ramsay Hunt. He actually described 3 syndromes, and out of which only one is involving the facial nerve and the ear. The Ramsay Hunt syndrome type 1 is a rare form of cerebellar degeneration, and is also known as dyssynergia cerebellaris myoclonica or Ramsay Hunt cerebellar syndrome, which involve myoclonic epilepsy, progressive ataxia, tremors, and cognitive impairment. The type 3 is a neuropathy of the deep palmar branch of the ulnar nerve, and sometimes it's called the Hunt's disease or artisan's palsy. And it's only the syndrome type 2, which is the most well-known type and is known as the herpes zoster oticus. It's caused by the reactivation of the varicella zoster virus from the dormant viral particles resident in the geniculate ganglion of the facial nerve, and sometimes also in the spiral and vestibular ganglia of the 8th nerve, leading to a lower motor neuron palsy of the ipsilateral facial nerve, earache, and a herpetic vesicular rash, which may be present on the concha, the external auditory canal, the tympanic membrane, the retroauricular sulcus, pinna, the face, or even in the oral cavity. Now, the varicella zoster virus is a human herpes virus, a DNA virus, which causes chickenpox in humans. Following primary infection, the virus persists in the dorsal root and cranial nerve ganglia for life. And later in life, reactivation and replication of the virus can lead to various clinical manifestations depending on the site of the reactivation. Classically, reactivation is in the form of herpes zoster, or which is also known as shingles, which manifests as the cutaneous eruptions in a thoracic or lumbar dermatome. And reactivation is associated with increasing age, immunosuppression. The head and neck occurrence of herpes zoster is reported as accounting for up to 35% of the cases. And now, what is labyrinthitis? Labyrinthitis is the inflammation of the inner ear, which is the cochlea and the vestibule or the balance system. Now, most commonly, this is caused by viral infections, the common agents being measles, mumps, Epstein-Barr virus, cytomegalovirus, and herpes zoster. And Ramsay Hunt syndrome is a rare cause of labyrinthitis. Most have isolated vestibular dysfunction of the sudden onset, but hearing loss may not be there. While the syndrome typically involves the facial and the vestibulocochlear nerves, significant inner ear inflation, such as in labyrinthitis, is rare but can occur in severe cases, and it reflects the more widespread viral involvement or immune-mediated damage to the inner ear structures. Globally, incidence of Ramsay Hunt syndrome is around 5 per 1 lakh people per year, and the incidence in India is not precisely documented in any population-wide studies. It's the second commonest cause of unilateral facial palsy after idiopathic Bell's, but it has a poorer prognosis. Females are more predisposed, and published cases of true labyrinthitis cases highlight it as a severe complication in a minority of patients in those with extensive viral involvement or immunosuppression. And the factors which influence the occurrence of Ramsay Hunt syndrome are individual immune status, advancing age, and the history of varicella zoster infection. Now, the virus, after causing acute chickenpox, remains dormant in the cranial or spinal ganglia. Decades later, the virus breaks the latency and reactivation occurs under various conditions like immunosuppression, stress, or age. But it replicates first in the geniculate ganglion and then travels down the peripheral nerve, leading to inflammation and nerve dysfunction. So now let's look at the pathway of the facial nerve in brief now. Facial nerve, as we all know, is the seventh cranial nerve, and it's a mixed type of nerve. It has firstly the motor fibers, secondly the parasympathetic fibers, and thirdly the sensory nerve fibers. Now, the motor nerve fibers, which supply the muscles of facial expression, which are derived from the second branchial arc. Hence, these fibers are also known as the branchiomotor fibers. Its nucleus, which is known as the facial nerve nucleus proper, is located in the lower pons. The motor fibers arising here, they move backward from the proper nucleus towards the fourth ventricle. It will curve around the nucleus of the sixth cranial nerve, take a U-turn, and then again take its original route to exit by the pontomedullary junction. The parasympathetic fibers, which help in salivation and lacrimation, its nucleus is in the superior salivatory nucleus in the lower pons. And the third, the sensory fibers that carry the taste sensation from the anterior two-thirds of the tongue, they are centrally connected to the nucleus tractus solitarius. Also, some fibers which carry touch, pain, temperature sensations, they are centrally connected to the spinal nucleus of the fifth cranial nerve or the trigeminal nerve. The sensory and the parasympathetic fibers, they will form a tight bundle known as the nervus intermedius and exit together with the branchiomotor fibers through the internal auditory canal, which connects the posterior cranial fossa to the medial wall of the middle ear. The internal auditory canal, as we all know, contains now the seventh nerve and also the eighth cranial nerve. At the anteromedial wall of the middle ear is the geniculate ganglion, which is the sensory ganglion lying in the geniculate fossa at the distal part of the labyrinthine segment of the facial canal at the first G2. Now, the geniculate ganglion is surrounded. Superiorly, we have the middle cranial fossa. Medially is the cochlea. Laterally is the tympanic cavity. And posteriorly are the semicircular canals. The facial takes a sharp bend here, and that's why the name geniculate. Genu meaning a sharp bend, to form the horizontal tympanic segment, which then travels posteriorly towards the posterior wall of the middle ear and then vertically downwards, where the motor fibers will give a branch to the stapedius muscle. After exiting by the stylomastid foramen, it will give the posterior auricular branch, the posterior belly of digastric, and nerve to the stylohyoid. Then it will enter the parotid gland and it will give the 5 terminal branches to the muscles of facial expression from superior to inferior, namely temporal, zygomatic, buccal, marginal mandibular, and cervical. The parasympathetic fibers, they reach the geniculate ganglion, but they do not synapse here as it's not a parasympathetic ganglion. They will just pass through and separate here into the lacrimatory and the salivatory fibers. The lacrimetry fibers, they will go to the middle cranial fossa, exit through the foramen lacerum, and join the sympathetic plexus of the internal carotid artery in the pterygoid canal. And together, now it is known as nerve to the pterygoid canal or the Vidian nerve, and which will enter the pterygopalatine fossa. The preganglionic parasympathetic fibers will end at this pterygopalatine ganglion, and the postganglionic fibers will start here, which will travel now with the lacrimal branch of the ophthalmic division of the trigeminal, and through the superior orbital fissure, it will supply the lacrimal gland. Also, it will travel with the zygomatic branch of the maxillary division of the fifth cranial through the foramen rotundum and again supply the lacrimal gland. The salivatory fibers, they will travel with the facial nerve proper till the posterior wall of the middle ear. Then it will exit the facial canal. Through the pterygotympanic fissure, it will travel along with the lingual nerve, which is the branch of the mandibular division of the fifth, and it will separate from the lingual nerve ultimately to reach the submandibular ganglion, which is again a parasympathetic ganglion. The postganglionic fibers arising from the submandibular ganglion will ultimately supply the submandibular and the sublingual glands. The sensory fibers, also known as the cauda tympani nerve, it will carry the taste sensation from anterior two-thirds of the trunk, travel with the lingual nerve, then it will jump out and travel with the salivatory fibers to the geniculate ganglion. Since the geniculate ganglion is a sensory ganglion and it contains the cell bodies of the taste fibers, the postganglionic fibers will end here now, and the preganglionic taste fibers will run with the facial nerve proper to end at the nucleus of tractus solitarius. So that's how, in brief, we see that the fifth, sixth, seventh, eighth, all the cranial nerves are intimately interconnected. Now, the key mechanisms of nerve dysfunction includes nerve damage, inflammation which is caused by the reactivation of the virus. It impairs the axonal transport and causes demyelination, resulting in facial paralysis and other neurological symptoms. Spread to the adjacent nerves like the cranial nerve 8th, the vestibulocochlear, and the 9th glossopharyngeal explains the auditory symptoms like the tinnitus, hearing loss, and vertigo, as well as we see oral vesicles and dysgeusia. The immune response, that is the delayed hypersensitivity response, exacerbates the inflammation and the nerve damage. The labyrinthitis in Ramsay Hunt syndrome, it occurs either due to the direct viral invasion of the cochlea and the vestibular apparatus, or inflammatory damage to the inner ear secondary to the reactivation of the virus. Also, ischemia of the anterior vestibular artery is also postulated as one of the mechanisms in this. Now, the temporal bone studies have shown that in the facial nerve, we can find active neuritis with inflammatory cells, edema, hemorrhages, perineural and round cell aggregation, and axon degeneration throughout the facial nerve sheath, but maximally near the geniculate ganglion. The geniculate ganglion has shown inflammation, edema, and neuronal degeneration on these temporal bone studies. The facial nerve nucleus in brainstem is not involved. And the inflammatory cells are seen mainly along the vestibular branches of the 8th cranial nerve and the macula of the utricle and saccule. Also, atrophy of branch to the horizontal and superior semicircular canals with atrophy and loss of hair cells of cristae of the corresponding semicircular canal with fibrosis and new bone formation were also seen. So this disease can best be classified as a sort of encephalomyelitis spreading from the CSF to the meninges to the sensory and the motor nerve roots. Now, the typical symptoms will include, firstly, we have auricular pain, which is often the first symptom. Then we can have we'll have the facial paralysis, vesicular rash. Now, the rash is typically present on the concha, the external auditory canal, the pinna, the tympanic membrane, the retroauricular sulcus. But in 14% of the cases, rash is not present initially. It develops several days after the onset of pain and the facial palsy. In some cases, the rash may never be present in the ear, but it may be, in fact, be present on the tongue or the pharyngeal mucosa. And in 3% of cases, can be zoster sign herpeti or a facial palsy caused by the zoster virus, but with no cutaneous or mucosal rash. But the disease can be confirmed by the rise in the serological titers or presence of the zoster DNA in the skin. Then we can have the hearing loss and tinnitus. detailed audiological studies have shown that almost all patients with herpes zoster oticus, they have abnormalities of the auditory pathway at several different locations, from cochlea to the brainstem, even though subjective hearing loss may not be present. Subjective hearing loss occurs only in 25% of children and 50% of the adults. And then we can have an abrupt onset of severe debilitating vertigo with unsteadiness, nausea, vomiting. And the vestibulocochlear symptoms are apparently caused by spread of the inflammatory cells from the geniculate ganglion to the inner ear, to the spiral and the vestibular ganglia. And occasionally, patients may develop prominent vertigo or hearing loss before or along with the facial palsy, which may be mild. The most important signs are, firstly, we have the facial palsy. So we'll have the loss of forehead wrinkles, wide palpebral fissures, epiphora, absence of the nasolabial fold, inability to close eyes, asymmetrical facial muscle tone, asymmetrical smile, etc. Vesicular rash, as we already talked, it may or may not be present. And in the cases which are having vertigo, we will have a peripheral type of nystagmus, which is the contralesional horizontal rotatory nystagmus. And on a head impulse test, it will be positive ipsilesional, and deviation towards the disease side in the subjective visual vertical test and the Unterberger's test may be seen. Now, the diagnosis is mainly clinical. MRI and CSF analysis, they have no role in diagnosis or prognosis. But on MRI, we may see enhancement of the involved geniculate ganglion and the facial nerve, as well as the vestibulocochlear nerve and parts of membranous labyrinth. And there are also reports of MRI showing enhancement in the distal internal auditory canal and labyrinthine segments of facial nerve too. But MRI may actually be confusing in acute stage, as inflammation of nerve in the internal auditory canal can be mistaken for a small vestibular schwannoma. Diagnosis can be confirmed by isolation of the virus from vesical fluid, from the virus DNA by PCR in the vesical fluid or the facial nerve sheath or the CSF, and histologic presence of the multinucleated giant cells in the vesical scrapings. Coming to the management of Ramsay Hunt syndrome with labyrinthitis includes a multimodal treatment, and it includes antiviral therapy, corticosteroids, symptom control, vestibular rehabilitation, and supportive care. Early initiation, that is within 72 hours of symptom onset, is critical to optimize the outcomes. Antivirals are used to inhibit the viral replication and most effective when started as early as possible and within 72 hours of symptom onset. Acyclovir is given as 800 mg 5 times daily for 7 to 10 days, but IV acyclovir may also be used in severe cases or immunocompromised patients. Now, valcyclovir is preferred for better bioavailability and less frequent dosing, and hence better patient compliance. Famciclovir is also an alternative now. Now, the MRI and PCR studies have shown a more extensive viral attack than was earlier believed to be the case. And owing to the risk of remaining cranial nerve dysfunction, antiviral treatment should be initiated as soon as possible. Corticosteroids are given. It reduces the inflammation and nerve edema and improves the nerve recovery. Prednisolone at a dose of 1 mg per kg per day is given for the first 5 to 7 days, and then it can be tapered over the next 3 weeks. But we have to monitor the blood glucose and the blood pressure, especially in patients who are having comorbidities. Now, the supportive measures, including analgesics for pain control, NSAIDs and ibuprofen, diclofenac, paracetamol can be given for mild to moderate pain, but we might need opioids for like tramadol for severe pain, and gabapentin or pregabalin for neuropathic pain and post-herpetic neuralgia. Then we will need artificial tears and eye patches for patients with incomplete eye closure. And artificial tears may need frequent installation during the daytime, and lubricating eye ointments at bedtime, eye patches or taping at night to prevent the cornea and to prevent the exposure keratitis. Now, in patients who are having the vertigo, we'll need vestibular suppressants like cinnarizine or dimenhydrinate or prochlorperazine for the initial vertigo management and vegetative symptoms, preferably for up to only 3 days, as beyond that it will delay the central compensation. And very important is psychological support to address the social and emotional distress with long-term facial disfigurement when it occurs. Now, rehabilitation. For permanent hearing loss, we might need hearing aids, and physiotherapy has to be given for facial muscle recovery from day one of treatment. Vestibular rehabilitation will need the Cowthorne Cooksey exercises, which are designed to help individuals with this balance disorders, and these exercises will involve the controlled head and body movements aiming to retrain the brain to integrate the sensory information and improve the balance. Now, the purpose of the exercises is vestibular habituation. Repeated exposure to movements that trigger dizziness helps the brain adapt and become less sensitive to these sensations. These exercises also help retrain the eyes and the brain to work towards maintaining a stable vision during head movements and improving the coordination between the eyes, head, and body. These exercises can improve overall balance and reduce feelings of dizziness. Yoga exercises like pranayam, bhujangasana, salabhasana, they're all beneficial for central compensation and long-term rehabilitation. And we have a very dedicated Ayush department in our hospital, and we take full benefit of that. Now, prevention. Children are routinely now vaccinated against chickenpox, having a 2-dose schedule in India, first dose at 12 to 15 months, second at 4 to 6 years, and which greatly reduces the chances of becoming infected with the chickenpox virus. And now, a shingles vaccine for adults above 50 years of age is highly recommended. The Shingrix vaccine is brought out by GlaxoSmithKline, and it's a non-live recombinant subunit glycoprotein vaccine. 2 IM shots are given at 0 and 2 to 6 months. It's recommended by ACIP for all patients above 50 years of age. It's 97% effective against shingles for people aged 50 to 69 and 91% effective against shingles for people aged more than 70 years of age. It's 88% effective against post-herpetic neuralgia. Zostavax, which was the vaccine earlier available, it's no more available in the USA as of 2020. So now the key ACIP recommendation, the ACIP is the Federal Advisory Committee on Immunization Practices in the USA. It recommends Shingrix, which is a recombinant zoster vaccine for the prevention of shingles and related complications in adults aged 50 years or older. It's also recommended for immunocompetent adults who has previously received the Zostavax vaccine, and 2 doses are given intramuscularly 2 to 6 months apart. Vaccination with Shingrix is recommended even if the person has had shingles or previously received Zostavax or the varicella vaccine. Now, CDC also recommends Shingrix whether or not they report a prior episode of herpes zoster, whether or not they report a prior dose of Zostavax, a shingles vaccine that is no longer available, and it's not necessary to screen either verbally or by lab serology for evidence of prior varicella infection. There is no specific amount of time you need to wait before administering Shingrix to the patients who have already had the herpes zoster, but however, you should not give it to the patient who are experiencing an acute episode of zoster. Preferably wait for 8 weeks, and it can be administered concomitantly at different anatomic sites with other adult vaccines, including the COVID-19 vaccines. More than 99% of adults aged 50 years and older worldwide, they have been exposed to varicella zoster virus. And hence, ACIP considers that people born prior to 1980, they are immune to varicella. Therefore, even if a person does not recall having chickenpox, serologic testing for the varicella immunity is not recommended, which often is a barrier to the zoster vaccination, and false negatives are common. But if serologic evidence of varicella susceptibility becomes available to the healthcare providers then should follow the ACIP guidelines for the primary varicella vaccination. Shingrix has not been evaluated in persons who are seronegative to varicella, and it is not indicative for prevention of varicella. 2 doses of vaccine has also been advised by CDC for immunocompromised patients 1 to 2 months apart in adults who are 19 years or more who are immunocompromised or will be immunodeficient because of some disease or therapy. There is no maximum age for receiving the shingles vaccine. And for pregnancy, we have to delay it until the pregnancy is completed. Now, is it contagious? Ramsay Hunt syndrome or herpes zoster oticus, it is not contagious. But if you have the condition, it means that you are having the varicella zoster virus. So the virus can spread if someone comes in contact with the fluid from the blisters that form in the affected person. It's most likely to cause chickenpox in people who have never had the disease or who have never got the chickenpox vaccine. And it can cause serious health issues in people who are having a compromised immune system. So it's good idea to avoid certain groups of people until the blisters scab over. And these include people who have never got the chickenpox vaccine or who have never had the chickenpox disease, people with weakened immune systems, newborns, and pregnant women. The complications, firstly, persistent facial nerve palsy may be present. For most people, facial paralysis associated with the Ramsay Hunt syndrome is temporary, but incomplete recovery of facial nerve function may occur, especially if the treatment is delayed. Secondly, post-herpetic neuralgia. It's a painful condition which occurs when a shingles infection damages the nerve fibers. The messages sent by these damaged nerve fibers, they become confused and exaggerated, causing the persistent burning pain in the area affected by the shingles rash, lasting even after the rash has healed or other signs and symptoms have faded. Then a permanent hearing loss may be present. Sensory neural hearing loss may exist. Vertigo and the balance disorders due to the involvement of the vestibular nerve, patients may experience the long-term dizziness or imbalance as well. The eye complications, inability to close the eye on the affected side can lead to dryness, corneal ulceration, eye pain, blurred vision, or even vision loss. Now, the involuntary movements may occur along with the voluntary ones due to miswiring during the nerve regeneration, causing synkinesis, like the eye closure when the person smiles, etc. And chronic facial disfigurement or pain may lead to anxiety, depression, social withdrawal, and they will have a psychological impact on the patient. Now, the various differential diagnoses for these conditions. Firstly, we have Bell's palsy, which is idiopathic unilateral facial paralysis, but often without the, obviously without the vesicular rash. Secondly, acute otitis media may also mimic this condition. There will be ear pain and effusion, but often without the neurological symptoms. Meniere's disease, again, vertigo and hearing loss will be present, but no rash. Acoustic neuroma, progressive hearing loss, vertigo due to the vestibular nerve compression, but there will be no rash or facial palsy. Lyme's disease may cause facial palsy, but it's often associated with systemic symptoms. Temporal bone fractures, again, it's a trauma-induced facial nerve damage and history of trauma will be there, but no vesicular rash. Vestibular migraine will cause vertigo with headache, but no rash or auditory symptoms are present. Vestibular neuritis will cause hearing loss, but again, rash is absent. And a central lesion like a cerebrovascular accident like the pica stroke or the ICA stroke, patient will not be able to stand due to severe vertigo, but there will be no rash or hearing loss seen in such cases. Now, this was an original case study that has been ongoing in our hospital, Central Hospital Maligaon, in the NF Railway. And we will go through the observations that we derived from this study. We conducted, it was a retrospective case study which started from March 2020 till October of 2024, and 4 patients were chosen out of 23 labyrinthitis patients, around roughly 17%. Patients are suffering from Ramsay Hunt syndrome with recent onset vertigo and sudden hearing loss, which was documented on video nystagmography or cranioculography and pure tone audiometry respectively, in the age group of 18 to 80 years were chosen. Patients who did not give consent or having long-standing hearing loss, chronic vertigo, or central disorders were excluded from this study. Clinically, patients were assessed after detailed history taking, clinical general ENT examination, along with a brief CVS CNS examination, particularly the cranial nerves, and a thorough examination of the balance system was done. The standing test, Rumberg's test, Unterberger's cerebellar test for incoordination were done. The nystagmus, the head impulse test, positioning test, skew deviation were all done. The Hinds test is a must to rule out ominous central disorders like posterior circulation stroke, and to differentiate between the central disorders and the peripheral disorders. Hinds is an acronym for head impulse, nystagmus, and test for skew deviation. The diagnosis was mainly clinical. Vestibular function test, VNG, was done in all 4 patients. Hearing assessment was done by pure tone audiometry in all the 4 patients. We did MRI in 1 patient because initially he was having a downbeat nystagmus. This was patient 1 with right-sided herpes zoster. This is again patient 2, patient 3, and patient 4. This is a VNG finding of the spontaneous nystagmus in the dark. I'll ask Dr. Anjana to please kindly play the video for this, please, ma'am.
Can you stop sharing? I'll play
Yes,
for
yes,
you.
ma'am. Yeah. So this is the patient. These are the findings of our patient number 3. He had a lesion in the left side, and so this patient is showing spontaneous nystagmus towards the right side, which is a contralesional nystagmus in the dark. Thank you, ma'am. We can go on to the next slide now.
Now you can share. I stop sharing.
Yes, ma'am. And so now this is the spontaneous nystagmus in the dark, the VNG finding. Here we can see contralateral nystagmus, that is a right beating nystagmus in a patient who is having a lesion in the left side. Here we can see the nystagmus, the pattern is pointing towards the right. Now on the high frequency head shake, the nystagmus was accentuated. On this caloric test, we can see a hypoactive labyrinth on the left side. This is his audiometry finding. We don't have an audiologist in our hospital, so we are doing it by ourselves. The patient is showing a left-sided sensorineural hearing loss with a moderately severe degree of loss on his left side, and the right side hearing was almost within normal limits. Now, 4 patients of Ramsay Hunt syndrome were studied out of the 23 labyrinthitis cases from 2020 to March of 2020 till October 2024, amounting to almost 17% of labyrinthitis cases. The male-female ratio was equal. We had 2 males and 2 females. Now, acute vestibular syndrome with sudden onset hearing loss and facial paresis of lower motor neuron type, it was seen in all 4 patients. Clinical examination showed the 3 patients had vesicular lesions in the right ear, while 1 patient had lesion in the left ear. 3 patients had vesicular lesions in the external auditory canal, pinna, as well as the preauricular area, while 1 patient had vesicles in only the external auditory canal, which could be seen only on otoscopy. 2 of the patients had ipsilateral facial palsy of lower motor neuron type grade 3 by House-Brackman, while 1 had grade 4 palsy and 1 had grade 5 palsy. Ipsilateral head impulse tests, contralesional horizontal nystagmus were present in all 4 patients, thus differentiating it from the ominous central lesions. History of chickenpox in childhood was present in 2 patients, and none of the patients were immunized against the virus, and 1 patient, they did not have the vaccine history, and 1 patient was immunocompromised. He had a history of a GI stromal tumor, which was operated a year back, and he was on immunomodulator called imatinib. 3 patients reported within the 48 to 72 hours, and 1 patient presented after 5 days. 2 patients were given IV methylprednisolone 125 mg 8 hourly for 5 days and then tapered over the period of 3 weeks. 2 patients received oral steroids, that is tab methylprednisolone 16 mg TAD for 5 days and then tapered over the period of 3 weeks. 3 patients received tab valcyclovir 1 gram TDS for 7 days, and 1 patient received tablet famciclovir. Now, imaging not indicated, but MRI we did for one patient because since he had downbeat nystagmus, but it revealed only age-related cerebral atrophy and no other clinically significant findings were seen. Pure tone audiometry was done in all the 4 patients. Unilateral hearing loss was seen in all 4 patients initially. 2 of them showed moderately severe hearing loss, 1 showed moderate mixed type of hearing loss, and 1 showed mild hearing loss. After 6 weeks, audiometry showed complete hearing recovery to normal in the 3 patients, but the patient, one of them showed a persistent high frequency loss. Video nystagmography findings. Initially, the VNG findings showed the head impulse test deviated towards the disease side in all patients, and the nystagmus was contralesional in acute phase, which was accentuated in the high frequency head shake, and which thus confirmed our clinical diagnosis, and caloric responses in all patients showed hypoactivity of the affected site. After 6 weeks, VNG was again repeated, which showed nystagmus only in high frequency head shake in all 4 patients. Now, the recovery facial palsy recovered completely in 3 out of 4 patients, while 1 patient who presented with initial facial palsy of grade 5 had residual paresis of grade 2 at 6 weeks of treatment. Hearing loss was recovered completely within 6 weeks in 3 out of 4 patients who reported early, while 1 patient who presented late after 5 days and initially showed persistent high frequency loss showed 6 weeks at 6 weeks. Hearing loss recovery was gradual, but it was complete in the other 3 patients. Vertigo symptoms subsided completely in all 4 patients within 24 hours of steroid treatment. Now, the clinical pulse, early recognition is the key. The triad of facial paralysis, vesicular rash on the external ear and the oral cavity, and the auditory symptoms should prompt immediate treatment. Distinguish it from Bell's palsy because presence of vesicles and pain differentiate its. Bell's palsy is idiopathic and obviously has a better prognosis. So we can give a very realistic expectation to the patient of a herpes zoster oticus. Initiate combination therapy antivirals with steroids as soon as possible, and it will improve both acute and long-term eye outcomes. Eye care is very critical to prevent the corneal damage with lubricants and protective measures. Vaccination reduces risk. So shingles vaccination in older adults reduces the risk of the virus reactivations and Ramsay Hunt syndrome and the associated complications. And we have to follow up on the auditory symptoms, and they might need hearing evaluations and audiological supports if the deficits persist. To conclude, Ramsay Hunt syndrome occurs by reactivation of the zoster virus in the geniculate ganglion of the facial nerve. Labyrinthitis is a rare but serious complication, and due to the anatomical associations with other cranial or cervical spinal nerves, various clinical features can present like tinnitus, hearing loss, vertigo, and nystagmus. Combination treatment with antiviral agents and steroids and early diagnosis is crucial factor to improve the damaged nerves. Early vestibular rehabilitation is a must in Ramsay Hunt syndrome labyrinthitis so as to improve the quality and productivity of life of the patients affected. These were the references that we took for our case study. Thank you.
Thank you, Dr. Ruby, for your presentation. And now we are waiting for expert to comment on your presentation. Over to Dr. Sumendranath Bandyopadhyay, sir. Sir?
Hello.
Yeah, you're audible, sir. We are waiting to hear from you,
Yes, yes.
sir.
I must congratulate Dr. Ruby Dole for her
Thank you so much.
excellent presentation. And I am really thankful to Professor B.K. Das, sir, and NEB AOI for allowing me to be present in the meet. I was a fan of your meetings because I think you have started with the deliberation on the temporal bone. And that was also an excellent session. This time also it is so engrossing that I find nothing more to add to what Dr. Dole has said. Anyway, this disease remains an enigma to me, um, because really do not know why the virus, varicella zoster virus, actually hibernates so long in the geniculate ganglion, and why it starts to wake up, why it decides to wake up. It may spread laterally or peripherally to reach up to the skin, or it may spread, or it may go towards the central nervous system uh, to involve the labyrinthine segment, the inner part of the or intracranial part of the facial nerve. And when actually it involves the labyrinth. So when the deafness, the labyrinth, when the patients started presenting with vertigo, and later they started the pain, and the vesicles appear even after that. So uh, the doctors started treating it as labyrinthitis, and the labyrinthitis, I think, when there is labyrinthitis, the patient will have sensorineural hearing loss and also with some vestibular symptoms. But we are never sure if the neurotropic virus actually involves the nerves or the labyrinthine cochlea. There is no way we can decide it, because I tried. The vesicles in the pinna and the introitus actually prevented me from performing photoacoustic emission to see if the cochlea is damaged or the cochlear nerve is damaged, if the vestibular nerve is damaged or the labyrinth is damaged. So I don't know actually how can we differentiate between the involvement of labyrinth or involvement of the nerve. At the same time, the prognosis. Dr. Dole is having a very good result with her cases, because 3 of the 4 had almost complete recovery. And it is not always so, and the patients continue to be tormented by the post-herpetic neuralgia, the pain that the patient feels even at the dead of the night, waking him or her up from her sleep. So this pain is very pathetic. And the uh, the sensorineural hearing loss. Here, 3 of our patients regained the hearing, but not always. You may not get the hearing back. So these are the enigmas that are still surrounding this disease. And there are 2 points I think Dr. Dole could deliberate on to add to his presentation. One is, can she consider intratympanic steroids in such patients, and when can we consider surgery for the persistent facial palsy? And if the damage of the inflammation is present in the geniculate region or in the labyrinth or canalicular segment, the prognosis is good. But when in MRI we get extensive inflammation, evidence of inflammation, including mastoids, including labyrinths, uh, and along the whole tract of the facial nerve, the results are not so good. So, can we decide on surgical options depending on the nerve conduction velocity, or electroneuronography, or MRI findings? These are my humble queries to Dr. Dole.
Uh,
It
Thank
was an excellent presentation. I must congratulate you. And if
thank you,
you
sir.
can enlighten us on these points.
Sir, thank you for the questions. I feel surgical, sir, decompression, we can only go if the nerve inflammation is localized. But if we have a generalized inflammation throughout the course, it will be difficult to, I think, decompress the nerve surgically. Firstly, I think so. And sir, nerve conduction studies will also only help if we, uh, I think, only in, sir, if it is a limited, sir, inflammation in the, I think, localized inflammation, only in those cases, maybe, I think so, sir.
Rather academic in pursuit.
Sir.
And how can we uh, uh, think about? Can you think about giving intra tympanic steroids,
Yes, sir. Intratympanic steroid.
especially in the
See,
immunocompromised if the patient is
yes, sir.
diabetic or
Yes, sir. Yes, sir. Immunocompromised patients, yes, sir, we can give. And for the mainly for, I think, for the hearing loss and for the vestibular symptoms, I think intratympanic steroids will uh, help a lot, sir. I think so. Yes, sir.
Thank you so much.
We
Thank you so
haven't
much.
tried, sir. Next time, maybe if we find another patient, we can give it a shot. Yes, sir.
Thank you.
Thank you, sir.
Over to Dr. Khanna. Swagata, ma'am.
Yeah.
Hi.
Hello.
Mm.
Yeah, I have a question. I
Yes.
think it is in the chat box. Regarding what are the long-term complication and how do you manage such conditions?
So,
Long-term complication.
Baidu,
Yeah.
before going to the question and answer, can you shift or some comment from moderator as
Sure.
well?
Yeah.
Mukherjee sir, your input in this subject. Mukherjee sir, unmute yourself.
Okay, now I'm here.
Yeah, yes, sir.
First of all, congratulations.
Thank you, sir. Thank you.
Your nice presentation.
Thank
I
you,
think
sir.
Dr. Bandhavata was also appreciated it very much. But some of the points has to be highlighted. Number one, that this policy can be confused with many other situations. As we have given differential diagnosis, ICA, PICA, stroke, vestibular schwannoma. One thing is that there are other conditions also which can cause palsy. Like you have told about Lyme's disease, tics,
Yes, sir.
reaction, and then you have told about the sarcoidosis. Then ubiquitous fever, that also can lead to this facial palsy. So then another point is regarding the steroid and this antiviral. It is the intuition on the part of the surgeon that when patient presents with rash and then painful rash, then you must have the intuition that the patient is going to develop facial palsy. Why not to start straightway steroid and antiviral straightway? That is one thing which comes in my mind. Number two, there is a condition called herpes Jones herpeti. That is where though it is a varicella, but vesicles doesn't come up in 50% of the cases. So in that case also, whether it is a herpes varicella infection or not, that you can prove right from there is no lesion, but from the skin smear or from the this secretions on the ER or fluid, if there is a infusion for the fluid itself, you can analyze for the IgG and IgM for this PCR for the this varicella zoster virus. Then third point, we have told about the exercise, but the basis behind the exercise is long-term potentiation, LTP. That means whatever residual nerve is there, that has to be geared up in such a way, and that has to be done according to the pathology. Say, suppose vestibule is a big area. So if suppose sacral is involved, then we have to give exercise for the sacral. We have ventricle involved. We have to give exercise for the ventricle. Then so also central canal. According to that involvement, we have to deal with that. Number 4, we have told about the labyrinthitis. Yes, labyrinthitis, it depends on the stage again. We know 4 stages of labyrinthitis, then fibrous and the calcified osseous. So it depends on the stage at which you are getting the patient. So if already permanent damage has been done, then definitely we cannot help much in that cases. Even any amount of intertympanic dexamethasone is not going to help. So we have to analyze each and every case very thoroughly to see at what stage the patient lesion is. We know very well that psychiatrist is going to happen in 16% of the cases. And the recovery only, there's only 10% will do completely. in respect to Bell's palsy 90%, whereas here it is only 10%. So we understand the pathology. It is the involvement of the nerve itself which is causing the whole problem. So again, another point: the involvement of the eighth nerve is not by the only the virus communication. It is a force anastomosis which is allowing the virus through that anastomosis involved with the eighth nerve. So there are a lot of actually the Ramsay Hunt syndrome is a big subject in the sense that it is a sad part of the patient that we cannot help them much because in spite of giving steroid and still the patient has a very monotonous life. Of course, your results were good that 3 patients recovered. That is something great. But again, when you are talking about this type of patients, we have to think about the long term. So suppose a patient has suffered for 2 years. Patient is 7 up to 6. Then we have to think about how to help them with the reanimation surgery. All these things will come up. Then this helping for the closure of the eye, canthal cataplexy, gold implant giving on the eyelid so that close the eyes, avoid the development of exposure keratitis, so on and so forth. So all these things will come up. So come up then you are very happy that you mentioned all the psychological. This is right. Actually so. Patient is very much depressed, a young girl or boy having cancer. It's very really sad. And more so when it is a viral infection and you cannot. We are very happy. Let us go through the chat box. What else question is there?
Dr. Fojia, your input, please.
Ruby, the presentation is very nice presentation.
Thank you, ma'am.
And you have touched it very nicely. Anatomy of facial nerve, I recall my anatomy days. So thank you very much for the awesome presentation. Labyrinthitis also you have explained and Mukherjee sir has given the nice description. I just want to add antiviral therapy. It should be given. It is actually it should be given. They say researchers say that it prevents synkinesis because synkinesis is there in most cases. Synkinesis is there and it is very disturbing. So antiviral treatment, if you can give it in time as early as possible, if patient comes within 72 hours, if you can give antiviral therapy, then synkinesis percentage is very less. It says, I think, if I remember, it is 65% less than without antiviral.
Yes.
And you have not told about House Beckman grading, I think, no? You didn't touch the grading of facial nerve paralysis.
No, I didn't touch that. Yes.
Be added because before therapy you should grade the palsy. Then only you can see how the progress is.
Sure.
And another that nerve damage grading is also very important. And another investigation, I think neutrophil leukocyte ratio is there. Neutrophil leukocyte ratio is very important for the treatment purpose. If it is high, then prognosis is not good. You can just see. And if it is low, prognosis is less. If it is high, prognosis is so these are the few things. Adato Mukherjee sir has said so many things. And eye care, it should be that leg ophthalmos care should be given. Counseling should be given to the patient how to take care of the leg ophthalmos eye care. It is very important just how to, in the beginning, how to paste with a tape or something so that it take care of the keratosis, not to abrasion should not be there. Thank you very much. Very beautiful presentation.
So we are actually running out of time. Can we take the question answers now? Can you assess your questions or do you want me to help it out?
Yes, ma'am, I can see here.
Okay, fine.
Hello, good evening, everyone. Thank you so much for the compliments here. Swagata ma'am has put up a question on what are the long-term complications of Ramsay Hunt syndrome. Ma'am, as we know, post-herpetic neuralgia, it's very common with Ramsay Hunt syndrome, which is actually very distressing for the patient. Also, the hearing loss may persist. The facial palsy may persist. The vestibular symptoms may also be there, and the eye complications, they can be present for a long time because already the cornea may be damaged during that time. The classical triad of Ramsay and Kalpana ma'am is here with the classical triad is with ma'am earache, facial.
Ruby,
Ha,
yeah,
sir.
just let me intervene. You just add one point, that is the synkinesis. Because
Yes,
when
sir.
the patient smiles, the eyes become
Yes,
closed
yes, sir.
like this. The synkinesis is a very cumbersome, it's annoying.
Yes.
Yes,
That's
sir. Yes,
Thank
ma'am.
you.
very
Yes,
important.
sir. Next, we have the classical triad of Ramsay Hunt syndrome is the earache, the facial palsy, and the vesicular rash, which is known as the classical triad. And then we have why symptoms are less in pediatric patients. I think because pediatric patients, they are the
Vaccinated.
immune status of the pediatric patients are better than the elderly patients. I think so, and also the zoster infects during the pediatric age. It will infect during the pediatric, and then it goes latent for the goes dormant for decades. So it already the pediatric age group is bypassed by that time when it becomes again activated. Then we have what percentage of patients recovered fully from facial palsy in Ramsay Hunt? The studies show that the facial palsy recovery rate is almost about 60 to 70%, and it's better in children, the pediatric age group. The adults, it's a bit lesser. Rarely involve function. Thank you, ma'am. Have you come across Ramsay Hunt syndrome with multiple cranial nerve palsy? Sir, I haven't come across, but I think Dr. Anjana has 2 patients with multiple cranial nerve palsy. Ma'am can say about this better, I think. Anjana, ma'am.
Yes, I have encountered 2 patients. Um they exactly, I don't remember actually. One patient came with encephalitis also. So it is because the cranial, it is a tendency to spread actually. So it's very common, multiple cranial nerve involvement, maybe along with the encephalitis, meningitis. It is very common in it. Literature says, but I lost a follow-up one patient, but after MRI actually. But in one case, I found like patient came with like brainstem involvement also. So I have referred the patient for MRI, and I lost a follow-up, but it can occur.
Okay. There has been published cases I have seen with atrial fibrillations along with Ramsay Hunt syndrome due to involvement of the vagus, they say. The published cases are there in the literature.
Hello, let me share with my one patient. Hello, is it
Hello.
audible?
Yes, sir. Yes, sir. You're audible, sir.
I had one patient with Ramsay Hunt syndrome with multiple cranial nerve palsy, and because of the 10th nerve palsy, initially he came with facial palsy, but later on, within a few days, we have seen that there is multiple cranial nerve palsy, and finally, because of the 10th nerve palsy, he had swallowing problem, respiratory problem, so many things has come. Ultimately, he had to end up in ICU, intubated, and he recovered well. He's some S. Bora. He's in still he comes to me. It is about, I think, 15 or 18 years back history, but he recovered completely and he's doing well. So that is the only one patient I have in my full career. The Ramsay Hunt syndrome with multiple cranial nerve palsy. Really, really, it is difficult
Rare,
and
very rare.
to treat in ICU with intubation. Thank you.
There are no
Any questions? Anything? Any queries?
I just want to add one thing, Swagata ma'am.
Yes.
In a long-term complication like synkinesis, if it persists, it is
Dr.
very cumbersome, as sir said. It is very
Dr.
cumbersome.
Yeah,
So
monocyte
this
related
can
cancer.
be tackled by botulinum toxin injection by
Yes,
there
yes,
are
yes, yes, yes.
Exactly, very correct.
botulinum
Yes.
toxin injection.
Last question is from Pradeep Sekiada. What is herpes zoster cephalicis?
Sir,
Multiple
sir, I think the head and neck, the cranial nerves, when it is affecting the herpes zoster.
Pradeep there?
Yes.
Yes, there are two terms now. One is herpes zoster oticus and herpes zoster cephalicis. Cephalicis is not common. And when there is multiple cranial nerve palsy, then we call it cephalicis with involvement of brain and other things.
Yeah.
It may goes up to meningitis and other things. Anyway, thank you.
Thank you, sir.
Okay.
There is no question in the chat box.
Yeah, you can
yeah.
give a vote of thanks on.
Okay. First of all, I would like to thank Professor Somendra Bandyopadhyay sir for joining us in this classroom, and also for wonderful presentation by Dr. Ruby Tole. And I would like to thank two moderator, Dr. S.N. Mukherjee sir and Dr. Fojia, for your wonderful moderation. And finally, I would like to thank all the participants who have joined this classroom, and also the organizers of NEBOI, President NEBOI, Secretary NEBOI, and also Chairman Scientific Committee, Dr. Sagata, Professor Sagata Khanna ma'am. With this, I conclude this session here. Thank you for being with us. Our next class will be on the month of June, second Thursday. Hope you all